I'm Ron Soler from San Diego, and it really is indeed a pleasure to be presenting at the NCVH Digital Education Series, and I do want to thank Dr. Walker for this opportunity. This morning I'll be talking about endovascular selective cerebral hypothermia. And here are my disclosures. I am a consultant and board member of Thermopeutics. So protecting the brain from ischemia is perhaps the most important unmet medical need. Globally, 1 in 4 people over the age of 25 will have a stroke in their lifetime, and nearly 2/3 will die or be disabled. In patients suffering a cardiac arrest, protecting the brain from anoxia is as important as fixing the heart. The challenge in treating ischemia is that there are many pathways that lead to cell death. Reperfusion of ischemic tissue is a prerequisite for salvage. However, reperfusion itself may lead to accelerated and additional tissue injury beyond that generated by ischemia alone. This is a phenomenon commonly referred to as reperfusion injury. And interestingly, TPA, commonly used in acute ischemic stroke and acute myocardial infarction, has been found to have pro-inflammatory properties that could possibly contribute to reperfusion injury. We know that hypothermia can result in very serious and even deadly clinical events. However, it can perhaps be the most effective therapy to mitigate the effects of ischemia. In the laboratory, hypothermia has been shown to be the most robust neuroprotectant because it acts on virtually all of the pathways that lead to cell death, including reperfusion injury. So hypothermia can protect the tissue during the ischemia as well as perfusion. Current therapeutic devices for hypothermia, as well as these techniques, all provide systemic cooling. So they cool the whole body in order to cool the blood that's flowing to the brain. And it's this cold blood that actually cools the brain. Not only are these techniques slow and unpredictable, the body naturally fights these attempts of cooling, and detrimental systemic effects, in particular cardiac dysfunction, limit systemic hypothermia to temperatures above which may be efficacious. In particular, in prolonged cardiac arrest, research has suggested further improvement can be obtained by cooling deeper as well as faster. And the experimental stroke literature has shown that there is a greater reduction in stroke volume at lower temperatures. So to protect the brain, instead of systemic hypothermia, perhaps a better approach would be to selectively cool the brain. Selective brain cooling by intra-arterial cold infusions has been proposed in the treatment of acute stroke. However, a recent study of this technique underscored the importance of catheter insulation. More importantly, there were concerns of volume overload as well as hemodilution using cold solutions. To address these concerns, direct infusion of cold blood into the carotid artery has been studied. In the mid-1990s, a group at Columbia University demonstrated in baboons that they could rapidly and selectively cool the brain to as low as 18 degrees centigrade by perfusing the internal carotid artery with cold blood. In a subsequent study, they showed that using this technique in a standard baboon stroke model, selectively cooling the brain to 24 degrees for 12 hours could dramatically reduce the stroke volume and maintain neurological function. The investigators attempted a transfemoral catheter approach to pump the cold blood to the internal carotid. But as found in the ice saline studies, the cold catheter sitting in the aorta resulted in systemic hypothermia, limiting the application of this technique. More recently, a Canadian team developed an elegant stroke model in large pigs and studied the twin flow catheter, which is a percutaneous active insulating catheter to selectively perfuse cold blood to the brain. In this study, 25 pigs were randomized to selective cerebral hypothermia at 26 degrees centigrade or normothermia following 3 hours of ischemia. Compared to the normothermic control group, there was no difference in systemic parameters. But most importantly, the rapidly induced selective deep hypothermia resulted in a statistically significant 10-fold reduction in the stroke volume. And the investigators concluded that endovascular selective hypothermia can provide neuroprotection within timeframes that are relevant to treating acute ischemic stroke. The twin flow catheter is a proprietary perfusion catheter introduced by standard percutaneous transfemoral technique that isolates the carotid artery and selectively perfuses the brain with cold blood. As illustrated here, blood is withdrawn from a port in the catheter located in the aortic arch. The blood is cooled extracorporeally and then pumped directly to the brain beyond a very atraumatic occlusion balloon so that the brain only receives cold blood. This countercurrent flow design very effectively insulates the cold blood from the systemic circulation. Other studies with this device in large pigs demonstrated the achievement of cooling rates up to 2 degrees centigrade per minute, brain temperatures as low as 15 degrees centigrade with minimal systemic cooling, and no adverse events. Initial clinical efficacy of the device has been demonstrated in the settings of neurosurgery and refractory cardiac arrest, where outcomes have been very dramatic in patients with very little options. For example, selective cooling to 26 degrees centigrade helped this giant aneurysm patient recover very rapidly, despite 42 minutes of occlusion that was required to make the repair. In this 38-year-old man who arrested with pulseless ventricular tachycardia and having no flow for more than 8 minutes, twin flow was used as a last resort after there was no response to 44 minutes of CPR and 10 hours of ECMO. Twin flow selectively cooled the brain of this patient to 22 degrees centigrade for 12 hours. The patient made a full and rapid recovery with no neurological deficit. And interestingly, this patient was a urological surgeon. And 2 months after he had found dead in his car, he was back at work performing Da Vinci robotic surgery. Additional cases of adding deep selective cerebral hypothermia with the twin flow catheter in the setting of out-of-hospital cardiac arrest have been reported so far in Taiwan, as well as mainland China. And although only about a dozen patients so far have been treated, the outcomes have been quite impressive. So, in summary, hypothermia can effectively protect the brain in the clinical setting. Time and temperature are the most important variables, and the technique of catheter-based rapid, selective, and deep hypothermia may offer a means to improve outcomes. Thank you for your attention.